we will be recording this, so I'm not sure if you want me to do that or you will be doing it, but start the recording here. Oh, it looks like it's already started. Okay. So good morning, good afternoon to all of you. Welcome to the 2024 Medicine Lecture Series as part of the Ohio State University Global One Health Summer Institute. My name is Sharon Clark. I'm a clinical associate professor of internal medicine and pediatrics and a hospitalist physician here at Ohio State. And I will be moderating the general hospital medicine lectures today, Wednesday, August 14th, and Friday, August 16th. As a participant, it looks like you can use the Q&A function, so please put any questions there, and I will be keeping an eye on that. But it looks like the chat function is also enabled in case there's any audience participation throughout the lecture. So I will go ahead and introduce our first speaker, Dr. Philip Hamilton. He is a clinical assistant professor of internal medicine in the Division of Hospital Medicine, and he will be teaching us today about sepsis and septic shock. All right, thank you, Dr. Hamilton.
Thanks, Sharon, and thanks for everyone for hosting me. Obviously a pretty big topic to cover in 45 minutes, but we'll try and make it through and leave plenty of time at the end for questions as well. And I have no disclosures to make. So today we'll be going through some objectives. I figured we'd just go through a case and go through a pretty common presentation of sepsis and just review the common screening tools that exist in order to identify sepsis, review empiric antibiotic selection in patients with suspected sepsis, discuss proper resuscitation strategies in sepsis and septic shock, and review a little bit of the controversy regarding how much fluid to give people. And then to do this, we'll be relying pretty heavily on the 2021 guidelines for sepsis and septic shock from the Society of Critical Care Medicine. And so, as always, we'll start with a case. So this patient is a 70-year-old female, history of hypertension, high cholesterol, and type 2 diabetes on oral therapy for her diabetes, who presents shortly after being discovered confused by her daughter. 2 days prior to presentation, she complained of some right upper quadrant abdominal pain, which was unrelieved with over-the-counter famotidine. Came into the emergency department with vitals notable for a temperature of 101 Fahrenheit or 38.3 Celsius. Heart rate was 120, blood pressure 87/54. She was a little bit tachypnic, but satting okay on room air. Labs were mostly notable for a leukocytosis to 21, lactate of 3, a bump in her creatinine to 1.6 from a baseline of 0.8, and a cholestatic pattern elevation of her liver function tests. So question number 1, what is the best screening tool available for sepsis? Is it using the SIRS criteria, QSOFA, Muse, or clinical judgment?
Dr. Hamilton, I apologize to interrupt, but we can actually see your slides in the presenter mode right now.
Thanks. Well, let me see. Is that better?
There we go.
Okay,
yep.
Cool.
Thank you.
I guess that gives away. Okay, so best answer would be clinical judgment. We'll discuss a little bit why here next. So take home point number 1 is just the importance of early identification of sepsis and septic shock. They're medical emergencies and they need to be treated with resuscitation and early empiric antibiotics immediately. So sepsis is, I think as most of us would know, a life-threatening organ dysfunction caused by a dysregulated host response to infection. The infection being key because a lot of the clinical signs that we see in sepsis are not specific to infection necessarily. A lot of different things can cause elevated heart rate and respiratory rate, fever, leukocytosis. Whereas septic shock is a subset of sepsis that's defined by circulatory and cellular metabolic dysfunction, which is associated with a significantly higher risk of mortality. When I was in medical school, we relied pretty heavily on the SIRS. Sepsis was defined as 2 out of the 4 SIRS criteria plus a source of infection. And the 4 criteria being either a high or a low temperature, elevated heart rate, respiratory rate, and then either a leukocytosis over 12 or a leukopenia under 4. And the advantage of this was that it is extremely sensitive for sepsis, and that's good for a condition that has such a high morbidity and mortality, and early treatment is so important. So, ruling it in is important, and starting appropriate treatment, thinking about it in the correct patient population can be really important for good clinical outcomes. The disadvantages is it's not very specific at all. If you think about all the things that can cause you to bump a white count or your heart rate to be elevated, dehydration, pancreatitis, recent surgery, allergic reactions, all sorts of things can give you at least 2 out of these 4. And so, further work was done to try and identify good tools to rule in or rule out sepsis more efficiently. And then a few years ago, they came out the new sepsis criteria that introduced the Q-SOFA criteria, which again, 2 out of 3 need to be present to be considered positive. And these 3 are going to be altered mentation, which they defined as a Glasgow Coma Scale less than 15, tachypnea with a respiratory rate of 22 or higher, and then hypotension, which is defined as a systolic blood pressure less than 100. So the advantage is that this is much more specific. And I think even more so, part of the reason this was designed was to try and help identify patients who are at risk of a worse clinical outcomes with sepsis. Because there's a subset of sepsis who, recover pretty much on their own from the source of infection, but then there's a subset that develop, septic shock and then, wind up in the ICU or pass away from it. And so trying to identify those patient populations that are at risk of worse outcomes is an ongoing clinical conundrum. And so the disadvantage is, though, is if you're using this as kind of a prospective tool for identifying sepsis, you're probably using it incorrectly, because it's a low sensitivity tool for a condition with a very high morbidity and mortality, where early treatment and resuscitation are so important. And so the guidelines actually say that neither SIRS nor Q-SOFA are ideal screening tools for the sepsis, and the bedside clinician needs to understand the limitations of each. Then they quote that of the 24% of infected patients, only 24% of them had a Q-SOFA score of 2 or 3, so Q-SOFA positive. But those patients actually accounted for 70% of the poor outcomes. So it is a decent marker of poor outcomes in those patients. So to emphasize that take-home point number 2, SIRS and Q-SOFA can be helpful as risk stratification tools, but it doesn't replace the importance of clinical judgment and bedside evaluation and evaluating patients who are developing sepsis. Okay, next question. Now that you've diagnosed your patient with sepsis, which of the following is the most important for improving mortality? Is it early administration of antibiotics, checking a lactate as a guide to resuscitation measures? Is it bolusing all patients with a 30 cc per kg IV isotonic crystalloid, or is it placing a central line to monitor central venous pressure?
Yeah, we have someone that says A.
Okay, yeah, good. That's correct. Early administration of antibiotics. That's good. I'll go through a little bit why and a little bit more about each one of these. And so this is a graph that is actually from a little bit of an older study. It's from a 2006 study from the Journal of Critical Care Medicine. But I thought it was really, really helpful for kind of emphasizing a point. The x-axis you can see is time from onset of hypotension. So this is the subset of patients who are going to be, your Q-SOFA positive, trending towards septic shock type patients, ICU players. But they look at the time from onset of hypotension until that patient got antibiotics. And the key here is going to be those black bars, and see how precipitously the survival fraction declines with every hour that antibiotics are delayed from being administered. And so, early antibiotics, especially in that patient population where they're hypotensive and shocky, is so critically important. And the guidelines actually recommend from time to identification to administration of antibiotics be less than 1 hour. And then as far as antibiotic selection, I think the guidelines are probably pretty appropriately vague for these. And so they use language that for all of these common bugs that we worry about in the hospital, that you're going to be wanting to think about kind of what your local patient population and what the patient in front of you is at risk for when deciding antibiotic selection. And so for patients with MRSA or methicillin-resistant Staph aureus, they recommend risk stratifying to decide whether they should have antimicrobial coverage for MRSA or not. And then similarly for patients presenting with multi-drug resistant organisms, if they're in shock and they're at high risk for MDR, think about your patients with bronchiectasis, your patients with cystic fibrosis, people who have been in and out of the hospital who have a history, a culture-proven history of multi-drug resistant organisms. Often they'll recommend using 2 antimicrobials with gram-negative coverage for empiric treatment over gram-negative agents. And then, whereas if they're considered low risk, they actually recommend just using one gram-negative agent. And they also use similar language to guide empiric antifungal. So they don't make a strong recommendation, just kind of risk stratifying your patient. Is this someone who has a gastric perf, or is this somebody who's getting chemotherapy and has cancer and is getting chemotherapy? Those are patients that you're going to be thinking about. Do they need empiric antifungal coverage as well? And so at our institution, we actually have a kind of a order set that kind of helps guide this. And clicking through, it's very directed. Whenever patients are presenting with sepsis, you're always interested in what the source of infection is, and so the kind of order set at our institution encourages people to order appropriate coverage that's kind of tailored towards what you think the infection is. And so I think some of these recommendations are also looking for the kind of undifferentiated shocky patient where the patient is so sick that you can't afford to defer antibiotic therapy, in which case a lot of times at our institution you'll start either vancomycin and piperacillin tazobactam or cefepime for your gram-negative coverage. And new in the guidelines from the update, there's actually more emphasis on antibiotic stewardship. And so there's language about kind of continuously reevaluating and searching for alternative diagnoses, and discontinuing antibiotics if an alternative cause of illness is demonstrated. Important to continually to get initial upfront culture data in order to be able to de-escalate antibiotics once culture data becomes available, so that you can use the most narrow coverage for your patients. And then they've also added language about deferring antibiotics for patients with a low likelihood of infection and who are not in shock, also to help with antibiotic stewardship. Okay, so to emphasize, take-home point number 3, early administration of antibiotics with a goal time of less than 1 hour saves lives. You want to risk stratify the patient in front of you to determine on empiric antibiotic selection, taking special consideration to the bugs that cause the most resistance in our health system, thinking about MRSA, resistant pseudomonal infections, and also antifungal coverage. And then also critically important to de-escalate your antibiotics as the culture data becomes available. Okay, and now for resuscitation. So the guidelines still recommend for patients with sepsis-induced hypoperfusion, starting with an initial fluid infusion of 30 cc's per kilogram of IV crystalloid fluid within the first 3 hours of resuscitation. And this has become a little bit of a hot topic recently. So this originally came from older trial from 2001, the Rivers trial, looking at early goal-directed therapy for patients with sepsis. The initial trial was a positive trial, improved mortality. But since then, there's been a lot of interest in kind of breaking down the bundle to see what was actually helping the patients. And there's a lot of strong feelings that a lot of the things that were helping patients in that was the protocolized care itself, the attention those patients were receiving, the early antibiotics that those patients got, and maybe less so the aggressive, central venous pressure monitoring that was a part of the bundled care. And also there's some comment that the control group in that trial had a pretty above average mortality. And so there's been a lot of studies, since then that haven't necessarily reproduced that, but this is one of the things that has kind of persisted and become a pretty widespread clinical practice, is the initial, IV fluid resuscitation for patients with sepsis and septic shock. And so some people have very strong feelings about this. This was a paper from 2020 in the Journal of Thoracic Disease that refers to it as the great 30 cc per kg hoax. And talking about, some of the risks of indiscriminate, volume administration in some of our patients who are coming in. I think some of the initial guidelines don't necessarily specify, whether the 30 cc's per kg should be for, a patient's total weight. Should it be based on their ideal weight? Should it, be applied, to patients with cardiac or kidney dysfunction? And just like thinking about, for our patients who develop septic shock and wind up on the ventilator, dry lungs are happy lungs. So, volume overload often leads to longer times on the ventilator, increased diuresis, increased acute kidney injury. And so the authors of this study, advocated more of a kind of judicious fluids strategy based on the patient in front of you, trying to focus more on the initial history. Is this somebody who came in, dehydrated, that you think that, is going to be more likely to be volume responsive than necessarily somebody who just has a pure infection and it has and is not necessarily dehydrated? Kind of continual reassessment of whether they're responding to the fluid bolus. I will say at our institution, the 30 cc's per kg is still part of the initial, sepsis bundle that we've incorporated. Although, for our larger patients, there is a button you can collect to make sure that you're using it based on their idealized body weight. And you're not like forced into it based on, if the patient is on dialysis or has a history of heart failure. There's more judicious things. So, remembering the patient in front of you and not indiscriminately ordering them a large fluid bolus can be helpful for patients. One of the newer recommendations, they actually made a recommendation for a specific type of IV fluid that's new to the guidelines. It is a weak recommendation, but it's based on some evidence. This is a relatively recent article that came out in the New England Journal, looking at balanced crystalloids, meaning things like Ringer's lactate and plasmolite, as opposed to like normal saline. And the endpoint for this was a composite of mortality, need for renal replacement therapy, and elevation of kidney dysfunction that persisted, that was greater than 200% of their original baseline creatinine. And that, based on that composite, the time point was 30 days or discharge from hospitalization, whichever came first. Based on that composite, it was a positive trial in favor of the more balanced solutions. So the idea being that these, lactated Ringers more closely approximates what is actually in your blood serum. You're getting, a lot less chloride. So they're seeing that, for people at least who get like, multiple liters of IV fluid resuscitation with normal saline, that's a really high chloride load that's causing a worsening, metabolic acidosis and increased, kidney injury in a lot of those patients. And so it's a little bit of a smaller, treatment effect, but it was enough to get them to recommend the balanced crystalloids as opposed to normal saline for resuscitation and sepsis. And then as far as presser selection, So they recommend using norepinephrine as first line over other vasopressors. And this is for generalized, just septic shock. If the patient's coming in with kind of a mixed shock picture with, cardiogenic and sepsis, there's language about considering dobutamine or epinephrine for those patients. But for patients with purely septic shock, there's a strong recommendation for like using norepinephrine as the first line agent for pressor selection, and then using vasopressin as being the second agent. The MAP target remains 65 millimeters of mercury for patients on vasopressors. That was found to be non-inferior to the 75 target that was used in one of the trials that looked at that. And so targeting MAPs of 65, at least initially for our MAP targets, is what's recommended. Okay, so circling back to our case, so you'll recall this is the lady who came in with sepsis and some right upper quadrant abdominal pain. We obtain a right upper quadrant ultrasound that shows some biliary duct dilation and cholelithiasis. So next question, which of the following should this patient undergo at this time? Should we scan the head, chest, abdomen, and pelvis looking for a source of infection? Undergo an MRCP, touch base with our GI colleagues for endoscopic retrograde cholangiopancreatography, or touch base with our surgery colleagues for a laparoscopic cholecystectomy. I wrote this for GI consult for C, thinking about getting source control. So take home point number 4, thinking about how critical source control can be for our patients. There's a couple different best practice statements in the guidelines over this, rapidly identifying specific anatomic diagnosis of infection, and then thinking about those ones that are not going to be sufficiently controlled by antibiotics. So specifically thinking about, pus under pressure, is this an obstructed kidney stone that's leading to pyelonephritis that's going to need some sort of urologic intervention to relieve the source of obstruction? In this patient, is this ascending cholangitis from a stone that's obstructed, that's going to need GI intervention to open up the blockage. And then also for patients, especially patients who have been in the hospital for a while or who have been in and out of healthcare settings and may have like implanted vascular access devices, ports, tunneled lines, that sort of thing. Those are folks that you're going to want to try and get out that line as soon as possible after other alternative vascular access has been established. Okay. So our patient is started on empiric piperacillin tazobactam and given a 30 cc's per kg IV fluid bolus of lactated ringers. Her blood pressure remains low, so she started on some norepinephrine and admitted to the intensive care unit. The GI team is planning for urgent endoscopy. Okay, so now she's in the intensive care unit, and so which of the following would be considered for this patient? A liberal blood transfusion strategy targeting a hemoglobin of 10. Intubation, and then followed by a high tidal volume strategy of ventilation, greater than 10 mg per kg ideal body weight. Starting VTE prophylaxis with low molecular weight heparin, or starting insulin with a tight glucose goal of less than 120.
We have a few answers of C in the chat.
Yeah, good. Thanks. C is correct. And so some of the guidelines include comments on some of the supportive care for patients who are admitted to the intensive care unit. So regarding transfusions, the adults with sepsis fall under the general category for most patients these days who don't have a cardiac history. We're using more of a restrictive transfusion strategy that's based on some strong moderate quality evidence. So for most patients, targeting a hemoglobin of 7 is appropriate. You know, as far as the patients who do wind up with sepsis-induced ARDS, there's a lot of evidence supporting a low tidal volume ventilation strategy. So 6 milliliters per kilogram of ideal body weight over high tidal volume. So, the idea being just trying to avoid, those secondary injuries for patients, and the high tidal volume putting our patients at risk of, barotrauma and worsening acute lung injury. Using pharmacologic DVT prophylaxis, really important for these patients who tend to be very sick, very pro-inflammatory, and often pretty immobile, at least in the short term. So really, really critical. And then for patients who have diabetes or are have stress-induced hyperglycemia, the recommended insulin level for these patients is going to be targeting keeping the glucose less than 180. And this is based on the evidence that goes all the way back to like the NICE sugars trial in the New England Journal that looked at tight versus loose constrictive control of glucose in the critically ill patients. And the patients who they targeted that glucose goal of less than 120 actually not only had more hypoglycemic evidence that incidents, they actually have an increased mortality. And so we can aim for a little bit lower goals when people are a little bit stabler and outside the hospital, but for most patients aiming for less than 180 is very sufficient. And then just rounding out the supportive care piece, that there's comments on risk stratifying your patients who are at risk for GI bleeding and considering stress ulcer prophylaxis for your patients who are on blood thinners or have a history of bleeding or are intubated. And then patients with sepsis, I recommend early enteral feeding as possible, ideally within 72 hours of when they're admitted to the hospital. Okay, so to wrap up the case, so our patient undergoes endoscopic biliary sphincterotomy with pus and stones visualized at the sphincter of Oddi. Blood cultures grow pan-sensitive E. coli. Antibiotics are narrowed to ceftriaxone. After a brief stay in the ICU, she's transferred to the floor and ultimately discharged home. Okay, so just to kind of reiterate some of our take-home points. Sepsis and septic shock, medical emergencies, high morbidity and mortality, early recognition and treatment are essential. There's no one risk stratification tool that totally rules in or rules out sepsis. It's important to maintain a high index of suspicion and use your clinical judgment. Early administration of antibiotics with a goal time of less than 1 hour saves lives. And then starting antibiotics isn't the end of the story. You need to make sure you have source control to ensure successful treatment outcomes. And then narrowing antibiotic coverage based on culture data as it becomes available, also critically important. Some of my references, and happy to open it up for some questions.
Thank you so much, Dr. Hamilton. It was definitely a very big topic to cover in a short amount of time. But I will also invite Dr. Amsalu, who is also one of the moderators, co-moderating with us, so to help kind of moderate some of the questions here, and then also maybe share some of the practices, over there, if there are any differences or anything. So we do have a few questions already in the chat. The use of steroids, if you could comment on that, and albumin.
Yeah, good questions. So the use of steroids, there was some language in the guidelines over using, empiric, stress dose steroids for people who are, in septic shock, admitted to the intensive care unit, and who are, not able to be weaned off of the, pressors or have increasing pressor requirements. And so, I think a lot of our practice, at least, I practice outside of the intensive care unit, but I think a lot of our practice is, initially to, start focus on like the antibiotics and, if they need it, starting on like pressors. And then depending on kind of what their pressor requirements are, considering, is this someone who is relatively adrenal insufficient given the acute stress on the body, and those are the patients that you consider, stressing with stress dose steroids. So yeah, definitely good question. And then use of albumin. So for first line for these patients, the initial fluid bolus is going to be typically going to be that isotonic crystalloid. So, ideally something like lactated ringers or plasmolite. For our, I tend to, reserve albumin for like kind of special subset populations, things like, cirrhotics who have, really low albumin, or, people who have like kind of other indications for it. Occasionally if you're trying to do like a kind of augmented diuresis type thing, but at least the initial resuscitation, the guidelines are still recommending, the 30 cc's per kg of isotonic crystalloid.
Yeah, thank you. I'm Salu from Ethiopia.
Great.
And from AAU. Nice. Thank you for your nice talk. It was a very detailed one, and I like the talk. You have already covered the most important parts of the talk. So in our experience, in our setup, we are sometimes in a difficulty to select antibiotics, particularly our culture and sensitivity results are majority in our patients are negative. They are not really yielding. I think that's the place where we are working to build up our setup in the yield of culture and sensitivity. So usually we tend to use the dual antibiotic therapy because of the issues that we cannot narrow the antibiotic therapy because of the poor yield of culture and sensitivity in our setup. That's what we are facing. The other important thing that we use is, that's very nice discussion. I like it. We usually use our clinical judgments in deciding in the diagnosis of sepsis. We don't usually fix ourselves to the criteria like SEERS or the quick SOFA score. So that's also, I think, a very important point that you are stressing, and I like it. Steroids, what we usually do is when patients are not responding for adequate fluid and following administration of vasopressors like norepinephrine, we tend usually to add hydrocortisone because of the essence of, where there is a doubt of probably there might be adrenal insufficiency. That's what we are practicing. In terms of fluid selection, that's what we are also following. Crystalloids are the best. We never use albumin. So that's what in our practice. But my question is one that I want to raise and to discuss is, what is the of antifungal treatment in your setup, and when do you like to start antifungal treatment if your patients are not responding for the usual antibiotic treatment? Do you have a special criteria, or what do you do?
I'm sorry, I caught the end of your question, but not the first part. Is what do you do if they're not responding to an initial antibiotic therapy, or?
My question is, when do you intend to add antifungal treatment when a patient is not responding for antibiotic therapy? Do you usually do like that? Like, for example, some of our specialists are considering of candidemia is an important cause of sepsis, particularly hematologic malignancy. So how is your practice, and what's your recommendation?
Yeah, it's a good question. And I think it needs to be kind of a case-by-case basis, a little bit based on, the guidelines don't give, really strong, clear recommendations. They recommend risk stratifying your patient in front of you, based on, what you think the source is. And so, someone who you're worried about a GI perforation, or if you do goat cultures back that show candidemia, obviously that's someone you would consider. Other patient populations that we see a lot, we see a fair amount of patients with substance use disorder and injection drug use. And so sometimes if you're worried about like a candidemia from that patient population, starting that. But yeah, if the patient's just not improving on, empiric coverage and you think you have everything and they're getting worse, sometimes, that 24 to 48 hour range, depending on what their clinical trajectory is, starting empiric coverage and evaluating their response is certainly reasonable.
We have a few other
Okay,
questions
thank you.
in the chat, or in the Q&A. Dr. Hamilton, do you want me to read them, or
Oh,
are you
yeah,
okay
that'd be
with them?
great. Thanks.
Yeah, so the first one was, thank you for the excellent presentation. For how long should we continue steroids for refractory septic shock?
How long to continue steroids for refractory septic shock? So I think part of it is depends a little bit on how how they're responding. If you think they responded to the steroids, so I think a pretty common regimen that I've seen is we use hydrocortisone as well, but 50 Q6 initially, and then kind of tapering it. I think most people have kind of a little bit of an individualized, taper protocol, but leaving them on that for a couple of days and then kind of tapering, by 25% every couple of days or so until they taper off, sort of thing. I think is pretty standard practice.
Okay, sorry. What is the role of lactate level determination in the management of sepsis and septic shock and your experience? Shall we use it strictly? Yeah.
With checking a lactate or yeah, so that is mentioned in the guidelines. They mention there's a weak recommendation for checking an initial lactate, and part of it is diagnostic, that patients with sepsis are more likely to have an elevated lactate, but it's one of those things it's very non-specific, because patients could have an elevated lactate from having liver disease and poor clearance. There's all sorts of things that can cause an elevated lactate, but in kind of the undifferentiated patient where you're not sure yet on sepsis, there's a weak recommendation in the guidelines about checking an initial lactate. And then our institution, part of our sepsis bundle does include lactate, and using lactate as a guide to resuscitation. So if your initial lactate is elevated, checking another one within a couple of hours to see if they've responded initially, and then to consider additional IV fluids if their lactate is still elevated. I think that's a little bit more controversial, just because of, is the lactate, truly showing, evidence of malperfusion, or is it more, the patient being, volume responsive, or is it more kind of tissue level malperfusion that's not necessarily going to improve with more IV fluid. But for now at our institution, it's still part of the sepsis bundle for kind of guiding resuscitation, though I think that's an area of active ongoing study.
There are more questions from the chat box. It says, thank you, Dr. Philippe. What is the practical evidence of adding vasopressin in vasopressor in reversal of septic shock? And another question, how much norepinephrine should be given before adding vasopressin if we didn't achieve target blood pressure?
That's a good question. And so I will admit, I'm not a critical care doc, so I some of this a little bit, I would if there is a critical care doc on the call, it might be helpful to hear their experience. But in my experience, the vasopressin, you start out the patient on norepinephrine, and then often if they're going up to 0.3, 0.4 of the levofed, and they're still not hitting their MAP target, then often around that that point, once they're on kind of higher doses of levofed, certainly before they're maxed out, starting the vasopressin to try and limit how much that they're needing on that, and then if still not sufficient with both of those, considering whether this is someone who needs like a third agent versus kind of starting to consider kind of like goals of care conversation with the patient at that point. But Usually I see it kind of in those medium doses of levofed where the levofed's being titrated up pretty quickly and they're not hitting your MAP goal, starting the vasopressin, at that point.
Thank you, Dr. Flip. There is also another question from chat box. Can you tell us your take 1 hour versus 3 hour bundle? Which one is more advantageous? Second question is about source control. Would you recommend opening abdomen for peritonitis patients with septic shock, which is not responding for treatment?
For patients with peritonitis, I guess I define between like spontaneous bacterial peritonitis, in a patient with like cirrhosis, where usually empiric ceftriaxone is going to get pretty good coverage of the the fluid, and you're not going to need physical intervention. For patients who I'm worried about, like more of a primary peritonitis, that's where I would definitely be engaging my surgical colleagues to see if that was someone that they thought they needed to go in. And if they have a concerning exam, getting advanced imaging to try and see if there's like a free air or possible perforation or anything. But for most patients with SBP, they tend to be pretty responsive to fluid, to the antibiotics. They tend to get pretty good penetration of the ascites fluid. But if they're not responding as expected, getting a repeat sample, seeing if there's like a different bug, or if the intra-abdominal leukocytosis is decreasing as expected, is definitely important. And then the first question, I think I heard it was a question about like 1 versus 3 hours, and I missed the first part of that question. Sorry.
Which one is more advantageous from your experience, 1 hour bundle or the 3 hours bundle?
For kind of initiating antibiotics, or for the sepsis bundles, you mean, or?
Yes, the sepsis bundles.
Okay. Yeah, I think our institution focuses on kind of like the 3 hour bundle, but I think one of the things that to me has like the clearest impact on mortality is early antibiotics. And so aiming for like from that time of recognition of like a true infection with sepsis and septic shock, trying to get them their antibiotics started as soon as possible, I think is one of the things that we have the best evidence for. And some of the other things that have come to be encompassed in the protocolized care, I think we're still a little bit unpacking from that 2001 Rivers trial in the New England Journal about which of these is actually helping the patients versus which of these is just like it's helping that we're saying sepsis, identifying sepsis, and having like a protocolized care, because like even just having a sepsis protocol, I think, is going to help outcomes in general. But I think the thing that to me probably makes the most impact on mortality is kind of the early antibiotics in shocky patients.
Okay, thank you, Philip. I think there is no more questions.
Cool.
So
thanks for having me, everyone.
questions.
I appreciate interaction and good questions.
Okay, so I think let's wind up the session. Thank you, Dr. Philip, Sharon, for a very nice discussion. Thank you, all participants. I think we have already finished our discussion. Thank you so much.
Yes, thank you. Learned a lot, and I think it was also really nice to hear, some of the limitations with the issues with getting appropriate cultures over there too. So we're a little bit ahead on time, which is wonderful. I do see Dr. Alzim is also already here. I don't know if you want to, Nabil, if you want to go ahead and test to see if you can make sure to share your screen. I know we're a little ahead, but.
Sure. Good morning. Let me try. So I'm sending request for share the screen.
You have to get, okay.
Okay, here we go. I think, yeah. You see my screen?
Yes, we see it.
Okay. Hello?
Does everyone, yep, I see your slides
Okay.
in the, kind of in the edit mode. What
I will
does
just
everyone think? We're a little bit, okay. We're a little bit
just
ahead on time. Do we want to, oh, go ahead, Nabil, sorry.
I'm sorry, I didn't mean to interrupt you. So you want like to take like a 5 minutes break, or you just let me know?
Yeah, that's what I was
what
just
you
going
like.
to ask. Does everyone want to take maybe a quick break since we're just a little bit ahead on time? We can take a quick quick break here, and then we can reconvene. Let's see, in about 5 minutes or so. Couple of minutes, and then yeah, I think about 5 minutes, and then we'll start. So
Sounds good.
Okay, we'll go ahead and get started here soon. Just want to draw the participants. There's a link in the chat to fill out an evaluation for the previous lecture. So if you could do that, that'd be really great. All right, and then now I would like to introduce our next speaker. So we have Dr. Nabil Alzain. He is a clinical assistant professor of internal medicine, also in the Division of Hospital Medicine. And he will be teaching us today about arrhythmias. Nabil, are you ready?
Yes, I'm ready.
Wonderful.
Thank you.
And I'm not sure if you want to have your video on or able to do so,
sure,
but we do not see your
Sorry
video.
about that.
Oh.
Here you go.
Okay, we see you now.
All right. Thank you, Dr. Clark. Thank you for the organizer for this summit. My name is Nabil Alzain, the Clinical Assistant Professor of Internal Medicine. I work with Dr. Clark in the Hospital Medicine Division. So, and good morning, everyone here, and good afternoon in Ethiopia, I think. So, today we're going to dive into the topic that is both critically important and often challenging in the clinical practice, which is the cardiac arrhythmia. So, let's see, sorry. You see my slide, right? So, arrhythmias are abnormalities in the rhythm of the heart, electricity, and they can range from benign to life-threatening conditions. So that's why, as healthcare providers, especially in the resource-limited setting, it's very important to understand and how to diagnose and manage such condition and patient to improve the outcome. Why arrhythmia matter? Because cardiac arrhythmia are the leading cause of morbidity and mortality worldwide, and they can present in various ways. As I mentioned, could be like asymptomatic findings on the EKG to severe cases of palpitation, syncope, or even sudden cardiac deaths. So our role as first responder and hospitalist or an internist in the hospital, your ability is very important. Your ability to quickly identify and manage arrhythmia could be the difference between the life and death for your patient. So that's why the aim of this lecture to give you a quick revision on some of the most important arrhythmia you may see in your daily life, especially as inpatient. So my objective in this lecture is to cover, as I mentioned, the fundamentals of the cardiac arrhythmia and identify the common one. We will discuss how to recognize the AFib, the flutter, SVT, including PNRT and APRT, multi-atrial focal tachycardia, VTAC, and the sudden cardiac death survival. And so the management strategy will explore the practical management strategies for arrhythmia and tailor to even the setting, even where resources may be limited. And during the lecture, I will go through a few case studies that illustrate the real world application of these principles. So we're going to start with one of the most common and clinically significant cardiac arrhythmia, which is the atrial fibrillation, or AFib. AFib is not just the rhythm problem, it's a condition that has wide-ranging implications for our patients' health, from increased risk of stroke to heart failure. How to diagnose AFib? Basically, maybe most of you know that we recognize on the EKG findings will include the irregular ventricular rhythm with absence of E wave in the whole EKG leads, and we will show you one sample on the next slide. There is some conditions mimicking the AFib on the EKG, which is the sinus tachycardia with premature atrial beats. the MAT or multifocal atrial tachycardia, especially we see that in COPD patients. Atrial flutter with variable conduction, and AFib can appear as irregular white complex tachycardia mimicking the VFib in the setting of underlying intraventricular conduction delay. Diagnostic study basically would depend on the EKG, the 12 leads EKG. Sometimes we check the TSH, make sure that the patient doesn't have.
Sir, we can't hear you well. The voice is a bit muffled. We
Sorry.
can't hear you well here.
Okay, sorry. Sharon, do you hear me?
It's a little
Is it connection?
staticky. I don't know if you have a headset maybe that you could use.
Okay, yeah,
or...
sure. Let me try that. Okay, now do you hear me better now?
Try talking again.
Yes. Do you hear me?
Yes, I think that's better.
Is it better? Or same?
I think it's
Think
the same.
better now. Or same.
I think I tried the headphone. Let me try another one, maybe. Sorry about that.
This one?
I use yes.
Dr. Nabil, it's
I
okay
think it
now.
was better with the headphones.
Okay.
Yeah, someone else in the chat says it's better. A couple people say it's
Okay.
better.
All right. So we're talking about the AFib. Do you hear that part?
This is
Yes,
this is
it's
better.
good.
Yep, much better.
Okay.
Okay. So as we discussed, to recognize the AFib, basically we depend on the 12 leads EKG. We see the irregular ventricular rhythm with absence of the P wave in all the EKG leads. There are some conditions mimicking the AFib on the EKG, and we mentioned the sinus tachycardia with premature atrial beats. We mentioned the multifocal atrial tachycardia, especially we see that in the COPD patient. Atrial flutter with variable conduction can mimic the AFib sometimes. And AFib can appear as irregular white complex tachycardia, mimicking the VFib in the setting of intraventricular conduction delay. We're talking about the diagnostic studies. 12 leads EKG, as we mentioned, we check the TSH, the digoxin level measurement, especially for patient they're taking the digoxin. We sometimes we refer patient to do like sleep study if we suspect sleep apnea, and of course the echocardiogram to see if there's like any structural abnormality. My voice is okay so far?
Yes, it is. Thank you.
Thank you. Now, well, these EKG, and the bottom one is showing the rhythm strip. Usually we look at here to see like the rhythm pattern that showed 2 sinus beats here and followed by the AFib started here. So irregular, and there is a right bundle branch block here. You see in this lead. So that's why it was, like a little bit here wide, complex, but this is AFib. This diagram from circulation, from the guidelines actually published in January 2024, and explaining, the major pillar of treatment of the AFib or management of the AFib. Basically, we're talking about the stroke risk, how to assess and treat. We'll talk about in the next slide about the CHADS-VAS score. Very important to optimize all modifiable risk factors like the obesity, hypertension, sleep apnea, diabetes, alcohol, tobacco use. And the last one is the symptom management, and that either through the rhythm control or rate control. Of course, as most of you know, if AFib with patient hemodynamically unstable, just go with do emergency electrical or pharmacological cardioversion for such patient. If you don't know the duration or more than 48 hours, so you need to start immediate, anticoagulation, and in that case, you need to at least like 4 weeks anticoagulation, and then you can do the cardioversion through this period. Rhythm control is mainly appropriate management for patients mainly with the heart failure, especially if they have reduced ejection fraction or the AFib less than 1 year duration, younger patient, and patients with fewer comorbidities. When we talk about the rhythm control, it can be achieved by medication or synchronized cardioversion or both. If the rhythm control is unsuccessful or not tolerated, then you need to refer to EP study for cardiac catheter-based AFib ablation, which is the more effective option. Ablation may be the first line therapy in younger people and more with symptomatic patients as well. The rate control, for chronic AFib or AFib with normal LV. Usually, we are targeting less than 110 heart rate. If we're doing the rate control, we achieve by calcium channel blocker or beta blocker. This is the CHADS-VAS score. This is the most popular or most common tool we assess for the stroke, risk of stroke, and to take the decision about the anticoagulation. So basically that we'll get like 1 point for the heart failure, hypertension, diabetes, vascular disease, and female gender, and age between 65 to 74 will take 1 point. If the age is more than 75, then we'll get 2 points. And if the patient has history of TIA or stroke, we'll get 2 points as well. So we calculate this score, and we'll see if the score is equal to or more in men, so that patient need anticoagulation. In female, we do if the score is 3 or more, so we'll do anticoagulation. And of course, warfarin should be used for anticoagulation in patient with valvular heart disease or rheumatic disease. I know that maybe in Ethiopia you have common rheumatic heart disease as mitral stenosis causing AFib. In that case, we'll use the warfarin. Otherwise, other non-valvular disease, so we use the direct oral anticoagulant, the DUAC, or like the Eliquis and the Xarelto and so on. So this slide talking about the antithrombotic option in patient with AFib. So we calculate the risk if the risk is more than 2% per year. So this patient, class 1 indication to be on anticoagulation. The patient risk of stroke 1 to 2% per year. So this is the class 2A, reasonable to put on anticoagulation. Then how to the anticoagulation choice, how to select the medication, as we mentioned, the DUAC now the standard of treatment for anticoagulation for patients. They don't have valvular disease, warfarin for patients with mitral stenosis or mechanical heart valve. Now, I know that in the past we used to sometimes use the aspirin or Plavix. This is no longer, and that there is no evidence that will benefit. In opposite, there is like maybe some harm. So aspirin either alone or Plavix or clopidogrel not recommended to reduce the risk of stroke. And the last one is if there is no risk factors for stroke, aspirin to prevent thromboembolic events not recommended. So remember, only warfarin is indicated for valvular AFib. Antiplatelet therapy alone is no longer routinely used for stroke prevention in AFib. And don't begin calcium channel blocker or beta blocker or digoxin in patient with AFib with Wolff-Parkinson-White syndrome. And we'll talk about that in the next few slides. Use procainamide instead. Adenosine is not effective in cardioversion of AFib, and we'll see when do we use the adenosine. Now, again, with the AFib and stroke prevention, double therapy versus triple therapy. In patient with AFib undergoing to PCI for acute coronary syndrome, anticoagulant and antiplatelet therapy are necessary. So we use the P2Y inhibitor like the clopidogrel or ticagrelor, plus the oral anticoagulation is preferred to the P2Y inhibitor and oral anticoagulant and aspirin. So what we say is double therapy, not the triple therapy. So in patients with AFib and stable coronary artery disease, we treat with rivaroxaban alone is non-inferior to rivaroxaban plus aspirin. So it's effective just like one agent compared to rivaroxaban with aspirin in the CAD stable. They don't have like any active ACAs. They don't have recent PCI. This is quick case, and I would like really if people can share on the chat about the answer, just maybe 2 minutes. So a 66-year-old man is seen in the office after hospitalization from embolic stroke 7 days ago. Initial neurological findings were minimal and have since resolved. Embolic source has not been identified. He has no other pertinent personal or family history. Medications they are using are the aspirin and clopidogrel. On physical exam, including vital signs, there is no neurological deficit. Ambulatory 48-hour Holter monitor showed no arrhythmia. So which of the following is the most reasonable management? Do we need to discontinue aspirin and clopidogrel and begin warfarin? Do we need to refer for left atrial appendage occlusion with Watchman device? Do we need to do loop recorder implantation or test for thrombophilia? I will give you 5 seconds, then see if it's like on here in the chat. Feel free to put your answer on the chat if you can. Gita Chu, thank you. So yeah, the correct answer is C, loop recorder implantation. This among patients aged 55 years or older with ischemic stroke or transient ischemic attack of undetermined source. Occult intermittent AFib or the hidden silent AFib is thought to be present in up to 25% of cases. So that's why we need like more prolonged ambulatory EKG monitoring may be indicated for detection. Another case, 76-year-old woman is evaluated during the wellness visit. She reports that she has fatigue. Her husband knows that she snores loudly. Medical history significant for hypertension. She takes metoprolol. On examination, the pulse 75% irregular, and the blood pressure is okay. Cardiac examination reveals irregular heart sounds with no murmurs or gallop, and there is no evidence of heart failure on examination. The EKG showed AFib, the heart rate 75 per minute without ischemic changes. Which of the following is the most appropriate management? And I will give you 10 seconds, then we can move on.
We have an answer of D. D. Another D.
We have more participants now. Yeah, I think you don't need the lecture here. Okay, good. So the answer is D. As you mentioned, like in stable patients with AFib, the primary goals of therapy is to prevent the stroke and control the heart rate. So in her case, the heart rate is already controlled. We need to start the oral anticoagulation, and also minimize the symptoms. If she has symptoms, and most likely, this fatigue and stuff sometimes can happen with the AFib. Modify underlying risk factors, very important in her case. Need to make sure her blood pressure is good. We check with other risk factors, diabetes, obesity, and so on. So anticoagulation is indicated for stroke prevention in patients with non-valvular AFib who have CHA2DS2-VASc score 2 or more in men or 3 or more in women. And in her case, her score is, I think, 1 to 3 at least. And now let's move to the atrial flutter. So atrial flutter is reentrant arrhythmia with atrial rates typically between 250 to 300 per minute. The EKG usually show this sawtooth pattern in the inferior leads and positive deflection in V1. And I will show you the next slide, the EKG. The ventricular response is often regular, although maybe irregular and can be confused with the AFib. Sorry. And there are two types of atrial flutter. The typical atrial flutter, the dominant form in the patient without prior cardiac disease, is the result of counterclockwise re-entry around the tricuspid annulus. The atypical flutter is primarily seen among patients with prior ablation for AFib, or they have cardiac surgeries. And in atypical flutter, the circuit is usually in the other location in the right and the left atrium. Here's the EKG, 12 leads EKG, and I don't know why the one. Okay, so yeah, the sawtooth pattern in the inferior leads to lead 2, lead 3, AVF, and there is this is the characteristics of the atrial flutter. Now, the treatment for the atrial flutter, basically, it's like very challenging and hard to do just straight control in atrial flutter. So, the catheter ablation is the definite treatment for atrial flutter because the very high success rate, more than 90%, not 95% with low complication. Oral anticoagulation or the management of the anticoagulation, the setting of chronic flutter is similar to that with the AFib. However, the rhythm control, as we mentioned, strategy is favored in the flutter because the rate control very difficult, and usually you need like very high dose of antiarrhythmic or more than one agent to control the rate with the flutter. And I think we're good with the time. We'll move to the SVT, or supraventricular tachycardia. So SVT are rapid heart rhythm arise from the atrium or require conduction through the AV node. So basically, AFib and flutter are technically SVT, but we don't use them like in our medical term with the SVT, although the term generally reserved for the narrow group of arrhythmia we describe here. So SVT can affect all age groups, but are frequently seen in younger patients. Prevalence is higher in women than men, and usually occur in absence of structural heart disease. Although echo should be performed to exclude underlying cardiac dysfunction or structural defects. So patients often have repeated episode of tachycardia, palpitation, very onset, like rapid onset and rapid offset, sensation of pounding in the neck sometimes, sensation of chest tightness, fatigue, lightheadedness, dyspnea, pre-syncope, and less commonly syncope. Premature atrial contraction and atrial tachycardia are early isolated beat that arise from the atrium. They are exceedingly common, and they are frequent. Their frequency increase with the age. During the Holter monitor or the EKG monitor, only 1% of persons have no PAC. This is according to the studies. So we're talking about the premature atrial contraction, the PAC now. The burden, usually the high PAC burden is associated with the increased risk of AFib. And symptomatic PACs are typically treated with beta blocker, calcium channel blockers. Atrial tachycardia, other kind of SVT, can arise from in the presence or absence of structural heart disease. Beta blocker, calcium channel blocker, the same, they are like first line treatment for symptomatic patient. Second line in that case with the catheter ablation or antiarrhythmic therapy. And now we're talking about the atrial tachycardia. And there's the other kind of SVT, the multifocal atrial tachycardia is typically 3 or more P wave different on morphologies, and the heart rate usually it's more than 100 per minute. So the diagnosis typically, EKG, narrow complex tachycardia. We're talking about the SVT now. Sometimes happen with wide complex tachycardia, more than one, the QRS 120, more than 120 millisecond, that present in cases with bundle branch block or aberrancy or pacing rhythm, or they have pacer, or antegrade accessory pathway conduction, what they call the antidromic tachycardia. So the EKG will show in the next slide. And there is 2 kind of the SVT tachycardia. The typical AVNRT often has the RP interval so short, and the P wave is buried within the QRX. We'll see, I think, in the next slide. Let me see here. Okay, so this EKG showed atrial tachycardia. Narrow complex tachycardia, P wave, most clearly seen in lead V1. And at the end of the T wave in the other leads here, this is the P wave here. So this is the atrial tachycardia. And we need just to move on here. This is EKG of multifocal atrial tachycardia. We'll see different or more than 3 different morphology with the P wave with different PR interval. This is the multifocal atrial tachycardia. You'll see here the P, different shapes and different interval here. And usually we'll see that in patient with the COPD or patient with lung disease or on inhalers. Now this slide will summarize the narrow complex tachycardia, either regular rhythm or irregular rhythm. When we see the P wave, will, morphology the same as sinus seen before every QRX complex. So this is the sinus tachycardia. Now, when the P wave just after the QRS, and we call it a pseudo R and lead 1, or buried within the QRS, this is the AVNRT. When we see the P wave short RP interval, so this is the AVRT. This is, the other condition with the SVT, like very common SVT. And when you see the P wave with long RP interval, this is the atrial tachycardia we talked about in the previous slide. Now, the irregular rhythm, when we see the P wave, at least 3 morphologies of the P wave. This is the multi-atrial tachycardia or multifocal atrial tachycardia. The P wave irregular baseline with no P wave, actually no P wave. So this is the AFib. And when we see the flutter wave or this the appearance in the inferior leads, this is the atrial flutter. Treatment of the SVT often terminated by Valsalva maneuver or carotid sinus massage. You would avoid the carotid sinus massage in elderly. Sometimes they have like some atherosclerosis, and some studies showed there's some risk of stroke. So the Valsalva vagal maneuver or Valsalva maneuver first line therapy to restore the sinus rhythm. So you try with that. If it didn't improve, then we'll go to the next step. So the next step will be adenosine, can be used to terminate the SVT and simultaneously help the diagnose its mechanism. Tachycardia that terminates with adenosine are typically AV node dependent, which is the AVNRT and the AVRT, whereas continued atrial activity, you will see continued waves during the AV blocking agent is consistent with atrial flutter or atrial tachycardia. So this is the AVNRT, atrioventricular nodal RT, account for the 2/3 of all cases of SVT, not including cases of AFib and atrial flutter. It's caused by reentrant circuit within the AV node that use both the fast and slow pathway. The AVNRT characterized by a short RP interval with retrograde P wave, inscribed very close to the QRS complex. Treatment may be terminated with the vagal maneuver or adenosine. AV nodal blocking agent like beta blocker or calcium channel blocker are used also. Sometimes if you don't have adenosine, and they should be used like for prevent recurrence of the episodes. In patients with recurrent AVNRT and those who don't tolerate or prefer the medication or beta blocker or calcium channel blocker, you can refer them to cardiac ablation, which has a high success rate. This EKG, the AV nodal reentrant tachycardia, showed the narrow complex tachycardia rate around like 140s per minute with no visible P wave. This is the AV reciprocating tachycardia or AVRT with normal narrow complex tachycardia with P wave just buried in the ST wave. You will see it here. I don't know if you see my cursor or not. This is, just do the laser here. Oh, there you go.
No, I don't think we can see your cursor.
How about the laser now? No?
Oh, yep, I see that.
Okay, you go. So you will see here the P wave buried in the ST segment here. I know this part is really tough, and sometimes like you have to like revise and study every time you have to revise, the criteria, how to differentiate between those, but hopefully you can get some points from these slides. So EKG demonstrating here the sinus rhythm with the pre-excitation as indicated by the presence of the delta wave. This is happened with the atrioventricular reciprocating tachycardia. So this layering of the QRS upstroke here represent the premature depolarization of the ventricular tissue adjacent to the accessory pathway. I will show the next picture. It shows the accessory pathway. So the atrioventricular reciprocating tachycardia, or the AVRT, is an accessory pathway mediated tachycardia that's often observed as pre-excitation. You will see the delta wave in the EKG as here. Early ventricular activation over the accessory pathway causes shortening of the PR interval, and initial part of the QRX complex is slurred because the premature ventricular depolarization in the myocardial tissue adjacent to the accessory pathway. This is the Wolff-Parkinson-White syndrome, defined by symptomatic AVRT evidence of pre-excitation on resting EKG. So sometimes AFib occurs in up to 1/3 of these patients with the WPW syndrome, and the rapid conduction over the accessory pathway in AFib can result in ventricular fibrillation and sudden cardiac death. That's why it's like very serious. And it is not really common, like maybe 1% of cases that happen with, you know, Wolff-Parkinson-White syndrome. So risk stratification for sudden cardiac death could be performed with exercise testing, although frequently patients are referred to EP specialists or electrophysiologists for to do the EPS and ablation, curative ablation. So catheter ablation is the first line therapy for these patients. Success rate for ablation is high, but it is dictated by the location of accessory pathway. Usually the antiarrhythmic therapy is second line therapy in these patients. Now, if the patient is asymptomatic with pre-excitation on the EKG, management here is controversial. Some people, they refer to EP to do like more invasive investigation. Sometimes they don't. Depends, I think, on the risk factors and the career itself. Like, for example, people, the pilot or driver for like trucks, so they need to do like more invasive testing. Treatment of WPW syndrome, we begin with procainamide or another class 1 or class 3 agent for patients with wide complex tachycardia, especially when AFib and pre-excitation are present. Cardioversion is preferred treatment for any patient unstable, and this is general rule in any kind of arrhythmia. Ablation of accessory pathway is the first line therapy for patients with pre-excitation and they have symptoms. Let's see here. Now we're talking about the ventricular tachyarrhythmia. So we're talking about the PVCs, or premature ventricular complex. Usually they are single or couple, or like pairs, or alternating with sinus beats. And you will see that maybe in healthy adults, and usually they are benign. The ventricular tachyarrhythmia consists of VTAC, VFib, and we'll talk about the torsad in a little bit. The characteristics of the ventricular tachyarrhythmia, usually the QRS more than 0.12 second or 120 millisecond. You will see AV dissociation. The classification of the ventricular tachyarrhythmia can be further classified according to sustained or non-sustained. Sustained, usually more than 30 seconds. If less than 30 seconds, we'll call it like non-sustained. VTAC is also categorized by morphology of the QRS complex. will have monomorphic VTAC. The QRS complex in the same leads do not vary in contour. The polymorphic VTAC, the QRS complex in the same leads do vary in contour. So differentiating the VTAC from the SVT with aberrancy, usually it's not easy and very important because the management will be different. VTAC is more common than the SVT with aberrancy. You will see that in the hospital, particularly in patients with structural heart disease, or they have like old MI and so on. So the any-wide complex tachycardia should be considered to be VTAC until proven otherwise. So this is, let me see here. So torsade de poids or torsades is a specific form of polymorphic VTAC associated with the long QT interval. Typically, it's short terminated spontaneously, but multiple successive episodes maybe result in syncope or ventricular fibrillation. Testing. Yeah, testing for the VTAC, resting EKG. Sometimes we do exercise treadmill and the cardiac imaging like echocardiogram to look for the structural heart disease. Treatment for ventricular tachyarrhythmia, patient without identifiable structural heart disease. So first line here, treatment for symptomatic PVCs, sorry, I'm talking with the PVCs, to suppress. So we'll do like a beta blocker or calcium channel blocker for patient without cause and they have symptoms. Calcium channel blocker, especially verapamil, beta blocker, are first-line therapy for idiopathic ventricular tachycardia. Patients with structural heart disease, usually if they have like ischemic cardiomyopathy, may present with a VTAC and should be considered for angiogram, heart cath, for revascularization if they have like any significant CAD. And if they have recurrent VTAC or ventricular tachyarrhythmia despite of beta blocker and antiarrhythmic medication, so catheter ablation may be considered. And of course, ICD placement is indicated for prevention of the sudden cardiac death in patients with structural heart disease, cardiomyopathy, or have sustained VTAC, or they have episode of VFib if reversible cause have not been excluded. Now, the acute treatment in the hospital, when you see the VTAC, and for unstable patients, so usually we do the cardioversion. Pulseless VTAC is treated in the same way as a VFib, remember that. And for hemodynamically stable patient with the VTAC, usually we use the procainamide, IV procainamide, or amiodarone, or sotalol are the therapeutic options. We're still good in time. Let me see. I think yeah, we're good. So here is a case, and you don't have to answer that. So 65-year-old woman with chronic stable angina with history of anterior MI, evaluated in the ER for palpitation and lightheadedness. Vitals are stable. EKG showed wide complex tachycardia with right bundle branch block. And there is no previous EKG to compare. So what is the most likely diagnosis and how to treat? So treat like wide complex tachycardia, we treat as sustained VTAC. Treatment, IV amiodarone or lidocaine. Now we're talking about the sudden cardiac death. When to screen patient with like sudden cardiac death. So unexplained premature, usually age below 35, death or survival. So so you need to screen for first-degree family member for any inherited arrhythmia syndrome. Diagnosis of sudden cardiac death is most often happen with structural heart disease or arrhythmogenic substrate, including hypertrophic cardiomyopathy, abnormal cardiac rhythm, or conduction or dilated cardiomyopathy with reduced ejection fraction, Wolff-Parkinson-White syndrome, Brugada syndrome, and long QT syndromes. So now the long QT syndrome may be inherited, but most of the cases are acquired. So patients usually they have syncope or sudden cardiac death as a result of ventricular arrhythmia. So we look for hypokalemia or electrolyte abnormality. We check the magnesium, make sure that they don't have hypomagnesemia. Medication-wise, there are like common medication can cause the long QTC syndrome and arrhythmia. We talk about the macrolide and the fluoroquinolones, especially the moxifloxacin. Talk about the antihistamine, antipsychotics, antidepressant medication, methadone, antifungals, and risk the class 1A and class 3 antiarrhythmic. And usually the risk is worse when the QTC is more than 500 milliseconds. So this EKG showed the Brugada syndrome. It is an inherited condition characterized by structural normal heart, but abnormal electricity conduction, and can cause sudden cardiac death. Classic Brugada syndrome is recognized as incomplete right bundle pattern, right bundle branch block pattern with coved the ST segment elevation in the lead V1 and V2. As you see here, this is V1 and V2. This is the coved ST segment elevation. Management of sudden cardiac death survival. So the testing, we do the EKG echocardiogram for survivors of the sudden cardiac death to identify the long QT, to see if there's like any anatomical abnormality, if there's like any, we assess the ventricular ejection fraction, and we'll assess the myopathy process. EPS study are indicated for patients with suspected ventricular arrhythmias, episodes of impaired consciousness, and structurally abnormal heart. A treatment, so treatment for these cases, treat the underlying cause, especially if they have coronary artery disease, do heart cath, revascularization. For patient inherited long QT syndrome, may be treated with beta blocker. And of course, the ICD is very important here in these cases, and it indicated for survivors of cardiac arrest resulting from VFib or VT, not explained by any reversible cause. After sustained VTAC in presence of structural heart disease, so this is secondary prevention, so we need to do the ICD because the risk of developing more recurrence will be high. After syncope or sustained VTAC or VFib on electrophysiological study in the EPS. For ischemic or non-ischemic cardiomyopathy with low ejection fraction below 35%. Of course, for Brugada syndrome with syncope or ventricular arrhythmia, they need ICD, and inherited long QTC syndrome not responding to beta blocker. And the last one is the more than 40 days after MI with repeated echo and still low ejection fraction less than 30%, they need ICD. So we're good at time. As we come to the end of the lecture, let's just recap the key points we covered today. Understanding and managing arrhythmia. As you see, arrhythmias are really complex with potential to significantly impact the patient outcome. So from causing simple palpitation to leading to life-threatening situation. So when you understand and recognize the various types of arrhythmia and knowing how to manage them, you have the power to make the real difference in your patient's lives. So diagnosis, the foundation of arrhythmia management lie on the accurate diagnosis, which often begins with the thorough history. You need to do like thorough physical exam, listen to the heart to see like any murmur if you suspect any structural heart disease, do the EKG, know how to interpret, even in resource-limited setting. So mastering these basics allow for early identification and treatment. We discussed the practical management approaches that can be applied with the resources you have, whether it's using medication to control the heart rate or the rhythm, administering the life-saving intervention in the emergency, or recognizing when to refer patients for advanced care or in the EP study. So each step you can take is critical. And beyond the acute management in the hospital, educating patients about their condition and ensuring regular follow-up is very important and essential part for preventing any complication and improving the long-term outcome. So your role as a future clinician, whether you are in the well-equipped hospital or rural clinic with limited resources, your ability to recognize and manage the arrhythmia will be life-saving. So in closing, I encourage you to continue building on this knowledge, stay up to date with the latest guidelines, and always think critically about how best to use the resource available for you. And arrhythmia may be complex, but with the right approach, they are manageable. This is my reference, and thank you for your attention, and happy to take questions.
Thank you, Dr. Alzaim. I do want to introduce Dr. Wosen, who is a cardiologist, also helping to moderate from the D2 Memorial Center. Sorry. If we can maybe take, we're a little bit on time, but we have time. We'll just make some time for a few questions here and then maybe some comments. Thank you.
Yeah.
Thank you. This is Dr. Wosen from D2 Memorial Hospital. It was a very nice, informative and clear presentation. I think we have one question. So someone is asking, what's the role of anticoagulation in multifocal atrial tachycardia? Is there a role of anticoagulation in MAT?
In atrial tachycardia?
Yeah, multifocal atrial tachycardia. Is there a role of anticoagulation?
I don't think there's any role for, or any study that indicate or guidelines indicate that there's anticoagulation indicated for atrial tachycardia.
Yeah, we usually treat the underlying cause of the MAT. That's the management of MAT. Any other question? Okay, someone is asking about the difference in orthodromic AVRT and antidromic AVRT.
Yeah, this is a really tough question. Usually, I'm not the specialist, but it's well studied, and there's a certain criteria. Usually, some cases like very difficult. I maybe better than me that some cases they really can't differentiate unless you do the EP study. That's what the electrophysiologist do, like to study the circuit and the electricity. So it's not really part of my expertise. And it's a really good question. I mean, every time I just need to read about that and compare the EKGs and how to differentiate that.
Regarding AVRT, antidromic AVRT, we expect a short PR interval, a wide QRS complex, and a delta wave. But the orthodromic AVRT is difficult to differentiate from the AVNRTs, and we might need electrophysiologic studies, but they usually present with narrow, complex, regular tachycardias.
Thank you.
Any other question? Just to share our experience, we have started to do electrophysiologic studies for the past 2 years in St. Paul Hospital, where I did my fellowship. This is the first of its kind, but we don't have our own electrophysiologists. Rather, electrophysiologists from abroad come to help us with these activities, and we have done ablations for AV-NRTs and AVRTs.
That's good. So I think
you.
maybe I have like some question to you, doctor. So how about the medication? Are they like the antiarrhythmic medication should be available to be used in by the internist, amiodarone, lidocaine, antiarrhythmic medication?
Unfortunately, we only have few medications like IV lidocaine, IV amiodarone, also a PO amiodarone, and the beta blockers. We don't have the rest of the antiarrhythmics. We don't have electrophysiologists, so the general cardiologists are the ones taking care of these patients. Got you.
And we were talking about the ICD. I know that's like very expensive here in the US. Not sure in Ethiopia they have like insurance or they have to pay out of pocket actually, and how much does it cost? I'm just curious.
Yeah, so ICD is available in some of the private setups. It's very expensive. It's about $5,000. $5,000, yeah. For the yeah, for it might not be that expensive for the other part of the world, but for us,
right?
it's
I understand.
very expensive. Yeah,
absolutely,
yeah.
Absolutely. I trained in Egypt, so I know we're talking about. Even we're talking about sometimes the heart cath or doing MRI for patients, they have to pay out of pocket. So it's a very challenging situation, unfortunately.
Yeah, same here.
Yeah. All right. Any other question? And thank you for your help today.
Thank you. I don't see any other question. I think we can wrap up here.
I do see something in the Q&A just about the role of digitalization. I'm wondering if that means digoxin in atrial fibrillation.
Yeah, I think that's the question. Is there a role of digitalization in atrial fibrillation?
Mm-hmm.
Yeah, I mean, you can answer this question, but to my in experience, usually we don't use it as first line treatment to control the AFib with RVR or rapid ventricular response because of the side effects and sometimes complications. But I'm not sure if in Ethiopia if you use it commonly as like digoxin to control the AFib. Usually we do the the beta blocker, calcium channel blocker. Then if it doesn't really control, then especially for patient borderline blood pressure, sometimes I use digoxin, but not the first line. And you may have some comment on that.
Yeah, we usually use either beta blockers, and if patients are in heart failure or if their blood pressure is low, we go for amiodarone for rate control. We don't have IV digoxin in the setup where patients present with fast ventricular response, with fast ventricular response. So it's a bit difficult to use PO digoxin in the setup. So we go for IV beta blockers or IV amiodarone.
Thank you.
Okay, thank you so much.
All right.
Well, let's.
Thank you.
Yeah, thank you, Dr. Alexander. Yeah.
Thank you.
All right.
Thank you.
Okay, well, we will move on to our last lecture for today. Dr.
Hi, good morning.
I see that you're here. Great. Yeah. Now let's test your slide sharing capabilities.
Okay. How's my audio coming through?
I can hear you fine.
Okay, good.
Thank you
Okay,
for
let me
checking that.
make this bigger for myself.
Oh, and for everyone, please take a look at the chat as well. There is the form for the evaluation for Dr. Nabil. Okay, we see your slides. Perfect.
Okay, good.
Okay, well, let's keep moving on to keep us on time here. So would like to introduce our final speaker for today, Dr. Adam Attar. He is a clinical assistant professor in internal medicine, also in the Division of Hospital Medicine. He will be talking to us today about the management of COPD. I do also want to introduce, we have Dr. Hanan Yusuf, who is from Addis Ababa University and an assistant professor of pulmonology and critical care. So will be our counterpart, also co-moderating and helping with some of the questions at the end here. All right, Dr. Adam, are you ready?
Yes. All right. Thank you
Okay,
so
thank you.
much
Take
for
it away.
inviting me today. I'm going to give a talk on the management of COPD exacerbations. Okay, I don't have any financial disclosures that would affect the content of my talk. So learning objectives for today. One, I'd like to define chronic obstructive pulmonary disease as well as acute exacerbations of chronic obstructive pulmonary disease. I'd like us to understand the basic pathophysiology in COPD. I would like us to be able to understand the core pharmacologic treatments in acute exacerbations of COPD. And then finally, for us to identify some both pharmacologic as well as non-pharmacologic interventions that can reduce the rate of exacerbations. So a lot of the content for my talk comes from the GOLD guidelines. GOLD stands for Global Initiative for Chronic Obstructive Lung Disease. This is a multinational group that reviews research in COPD and produces yearly guidelines as well as education on the disease. So how should we define COPD? Per GOLD, patients should meet 3 criteria. 1, there should be evidence of airflow limitation. So spirometry is important, that there's non-fully reversible with bronchodilation airflow limitation, the cutoff being an FEV1 to FVC ratio of less than 0.7. Second, there should be clinical symptoms, and this is respiratory symptoms such as dyspnea, cough, or sputum production. Finally, there should be some sort of exposure history. Cigarette smoking is one of the most common causes of development of COPD, but there are other contributors as well, and it's also possible for non-smokers to develop COPD from indoor and outdoor air pollution. One example of indoor air pollution is the use of biomass fuels, such as wood and stove burning in the home. COPD has a major impact. It's the 3rd leading cause of death worldwide. It's estimated in 2019, 3 million people died of COPD worldwide, and this is likely an underestimate. Based on some large epidemiologic studies, the prevalence of COPD stands around 10%. However, there is a large variation regionally as well as amongst nations in prevalence. In the United States, the costs of COPD are enormous. It's projected over the next 20 years, there'll be a cost of $40 billion per year. COPD is also a major cause of disability. In terms of disability-adjusted life years, it stands second only to ischemic heart disease. So I'd like to talk about just the basic pathophysiology of COPD. So there's multiple factors at play. There's both genetic and environment components and effect over the lifetime. So some examples of exposures is what we're talking about: smoking, pollutants, and this can lead to changes in the airway, loss of elasticity in the airway, as well as increased inflammations, and ultimately destruction of the alveoli. And this is known as emphysema. There can also be changes to ciliary function and mucus overproduction, and this leads to chronic bronchitis. And Each patient with COPD is different. There's different endotypes of COPD with different contributions of emphysema and chronic bronchitis. The pathobiology is also very important. There are patients who early in their life may have exposures to respiratory tract infections or restriction in their lung growth that can put them at greater risk of developing COPD. Ultimately, all these things interact, and this is still being studied, the pathophysiology of COPD, but then it leads to the manifestations or the phenotype of airflow limitation, as well as the clinical symptoms, respiratory symptoms, and it puts patients as well at higher risk of comorbidities, such as heart disease. This is a graph showing the example of normal lung function over the lifespan. Normally, patients or people have maximum lung function around age 30, and then it's normal as people advance in age for that lung function to decline. However, without exposure history, most people do not reduce their lung function enough at advanced age for it to be clinically meaningful to them. However, if there's more rapid declines in lung function, for example, as a result of cigarette smoking, then they can develop the manifestations of COPD. And then, as we noted, it's also important there are patients who early in their life, due to exposures to respiratory tract infections or restrictions in their lung growth, may be at increased susceptibility to developing COPD earlier in life and with lower amounts of exposure. So now let's get into defining acute exacerbations of COPD. I think a good definition for this, and per the GOLD guidelines, they say it's an acute worsening of a patient's respiratory symptoms from their normal day-to-day variation, and this leads to a change in their usual medications. Acute exacerbations negatively impact the quality of life, not only in the short term, but also in the longer term. In general, it can take several weeks to recover from a COPD exacerbation, but some people may not recover for even longer periods of time or even return to their pre-exacerbation state. In one study done, 20% of patients at 8 weeks had not returned to their pre-exacerbation state. Exacerbations also are known to accelerate the rate of lung decline in patients. The mortality is high due to COPD. After a first severe exacerbation, it stands at 50% at 5 years. The cardinal symptoms of an exacerbation include increased dyspnea, increased sputum volume, and increased sputum purulence. So this is a graph showing what we see in COPD patients. After a first exacerbation of COPD, patients are at increased susceptibility of developing further exacerbations, and they can get in a vicious cycle where these exacerbations get closer and closer together in time. As this happens, people worsen with not only their COPD, but with their other comorbidities. This is a graphical representation of the high mortality due to exacerbations. So on the left-sided graph, you see exacerbations over time. After even just the second exacerbation, risk of death increases by 2-fold. After a 9th or 10th exacerbation, it can increase as much as 5-fold. On the right-hand side graph is a representation of survival over time after a first severe exacerbation. And as we said, at the 4 or 5 year mark, there's a high 50% chance of mortality in these patients. So now I'd like to get into the core management principles of acute exacerbations, and I'd like to relate this to a case. So DZ presents to your emergency department. He's a 68-year-old man. He has a history of hypertension and type 2 diabetes. Unfortunately, yearly for the last 3 years, he's had pneumonia. He's also a current smoker with a pack year history of 38 years. He's on some blood pressure medications. He's on metformin for diabetes. His controller inhaler is Advair. On appearance, he's cachectic. He seems irritable and anxious. HPI, he complains that he's not been sleeping well lately, and he's been more fatigued and tired. He reports a change in his cough that's now thick and yellow-green sputum. On physical exam, you listen to his lungs. There's decreased breath sounds, there's expiratory wheezes, and there's crackles at the bases. His initial vital signs: blood pressure is somewhat elevated at 162 or 84, tachycardic at 111, respiratory rate in the high 20s. not afebrile, and his resting oxygen saturation on room air is 87%. So the first question putting to you guys is, how would you rate the severity of this patient's exacerbation, and do they need to be hospitalized? So the guidelines on severity exacerbation are not clear-cut, but some of the things that you look at are, as one, what is their change in respiratory function from their baseline? Also, do they have other comorbidities that increase their risk of complications? Per the NICE guidelines, a mild exacerbation will be defined as one that can be treated in the home setting without new medications. They may just need to use increase in their short-acting bronchodilators. A moderate exacerbation is categorized as one where they do need new medications. They may need steroids and antibiotics, but most of these patients can be still treated in the outpatient setting. Whereas a severe exacerbation is one, there's rapid deterioration in the respiratory status and necessarily requires the patient to be hospitalized. So what are indications for hospitalization? So some of them, as we're talking about, include change in respiratory function from their baseline, having elevated respiratory rates, signs of labored breathing, having new hypoxia compared to their baseline. Also, if they're failing to respond to your initial management, maybe in the outpatient setting, they were started on steroids, but they've not responded well yet. Also taking into account the comorbidities that the patient has that can put them at risk of increased complication, in particular cardiovascular comorbidities. And then what their home support is. Some people may not have enough social support to treat their exacerbation at home, or they may have cognitive deficits that limit their ability to have a change in treatment. So what are some triggers for COPD exacerbations? So by far, respiratory tract infections make up the majority of triggers. These include both bacterial and viral causes. Looking at the pie chart on the right, you see the breakdown of this, and 70 to 80% of exacerbations can have a bacterial or viral trigger. Some of these common bacteria include H. flu, Moraxella, strep pneumonia. Common viruses include flu, COVID, rhinovirus. The other fourth to a third of patients may have other triggers. For example, exposure to air pollutants. Here in the US last year, we had Canadian wildfires in the north, and that pollution came down into our region and led to increased rates of COPD exacerbations. Pulmonary embolism is not common, but it's estimated that 5% of patients presenting for an acute severe exacerbation may have concomitant pulmonary embolus. Aspiration is also not a negligible cause, and even silent aspiration can put patients at risk of COPD exacerbations. And then there's patients where it's idiopathic. You don't identify a clear trigger for their acute exacerbation. Whenever you're faced with a patient with a acute respiratory condition, you need to keep a broad differential and not anchor on COPD exacerbation. To think about the other common causes of respiratory decline, these include pneumonia, and a chest radiograph would be helpful here to look for that. As we're talking about, pulmonary embolus is always possible in these patients. So based on your clinical suspicion, you may think about getting a D-dimer or getting a CT of the chest. Heart failure, based on your clinical suspicions, you may work this up further by taking a look at their lungs, looking for pulmonary edema with chest radiograph or point-of-care ultrasound, or getting a BNP marker. Less frequent causes, but COPD patients are definitely at risk of pneumothorax. And this is where a chest radiograph would be important, or ultrasound. And then as we're talking about the comorbidity of cardiovascular disease, having cardiac ischemia or having cardiac arrhythmias, and it can be helpful in some patients then to have an EKG available or to trend troponins. So the goals of treatment in a COPD exacerbation are twofold. One, we want to reduce their symptom burden acutely and try to help improve their activity tolerance. Second, we want to try to reduce the risk of future exacerbations. And as we've talked about, this reduces the risk of future morbidity as well as mortality by reducing risk of exacerbations. This is a graph from the GOAL guidelines that summarizes some of the key treatments that we'll go over one by one, but they include bronchodilator therapy, steroids, antibiotics in some patients, and in some patients, you may need non-invasive mechanical ventilation. So now this gets us to our second case question. Does patient DZ need to be placed on oxygen therapy? And if so, how should you titrate it? To remind you guys, this patient's resting oxygen saturation was 87%. So for this patient, you would titrate to a goal of above 88 to 92%. It's important to note that pulse oximetry is not as accurate as an ABG for oxygen saturation. And pulse oximetry also does not give you data on CO2 retention. So it can be important when these patients who are coming in for more severe exacerbations that at the door you get a blood gas, and then if they have a change in their clinical condition, you may need to repeat that blood gas. In terms of if you're needing to follow along CO2 retention, in patients who are non-critically ill, hemodynamically stable, and not in sepsis states, a VBG can closely correlate with an ABG and be used in place. Why don't we titrate higher amounts of oxygen saturation? Take this patient above 95%. Why don't we titrate them up to 100%? There is detriment to doing this. One of the issues is there's the risk of developing oxygen-induced hypercapnia. The reason this develops is based on two mechanisms. One, normally the lung will divert blood away from less well-functioning units by pulmonary vasoconstriction, and this helps the VQ. However, if you increase oxygen saturation, this can then perfuse these poorly ventilated units and result in more VQ mismatch. Second, something known as the Haldane effect. Hemoglobin usually has a high affinity for CO2, but with increasing concentrations of PaO2 in the blood, this can bump off the CO2 and increase blood levels of pCO2. Case question 3. Should patient DZ be placed on inhaler therapy? And if you do, what type and what route are you going to choose? So short-acting bronchodilator therapies would be your key treatment here. These include beta-2 agonists as well as short-acting anticholinergics. Examples of beta-2 agonists would be albuterol. An example of a short-acting anticholinergic would be ipratropium. You can either give these by inhaler, metered dose inhaler, or nebulized. Initially, for these severe cases, the treatment can be pretty frequent upfront with albuterol, can give it continuously initially or even every 1 hour, and then as the patient tolerates, to try to space these treatments. In terms of giving it by inhaler or by nebulization, there was one systematic review done on this that did not find a difference in change in FEV1 between the two modes of treatment. However, it is important to note that patients who are sick and more ill may have trouble using their inhaler and thus getting effective medicine into their lungs. There have been no specific clinical studies that have looked at the continuation of long-acting inhalers in patients with acute COPD exacerbations and whether this is beneficial. However, it is thought that it is an opinion by GOLD is to continue long-acting inhalers if the patient can tolerate them, or assess for the start of inhalers if they're not on the right types already prior to hospital discharge. So your principles here are you're getting uptake at the beta-2 agonists and at your antimuscarinics first with your short-acting therapy, and then you want to try to continue to stimulate these receptors, and by adding in the long-acting inhalers or having them continue, this is available for that, and then allows you to space the short-acting. Okay, case question 4. Is there a role for systemic corticosteroids in DZ's exacerbation? So the answer here is yes. Systemic corticosteroids are recommended in moderate to severe exacerbations. Studies have been done on this topic and found that systemic steroids can improve lung function, oxygenation, and shorten recovery time and duration of hospitalization. In terms of how long you should put them on the steroid, in general, it should be around 5 days. The typical dose would be 40 milligrams of prednisone equivalent. And for patients with able to take by mouth, they have an intact GI tract, they're not vomiting, then oral steroids are equally effective to intravenous. So why should we use 5 days and not do longer amounts of steroids typically? 10, 15 years ago, it was common for us to use 14 days of steroids as the conventional treatment. Our study was done in 2013 called the REDUCE trial. It was a randomized study looking at 314 patients. The primary outcome they were looking at was time to next exacerbation. These patients were patients who presented to the emergency department in an acute exacerbation of COPD. The trial randomized patients to 5 days of prednisone versus 14 days of prednisone. What they found was between these groups, re-exacerbation rates at 6 months did not differ, nor did the time to first exacerbation. So the 5-day course was non-inferior to doing 14 days. So steroids are not a benign treatment. They have numerous side effects, especially with longer-term treatments. For example, patients with diabetes, hyperglycemia can be very troublesome. It can lead to mood dysregulation. And for patients who are getting frequent courses of oral steroids, this puts them at risk of secondary adrenal insufficiency. So next question for the case is, now that you know that steroids are indicated for his exacerbation, you start those, but then you go ahead and also put him on 5 days of doxycycline. What effect are you targeting with these antibiotics? So this is a multiple choice question. A, by doing so, you reduce the patient's mortality. B, this reduces the length of stay if a subsequent hospitalization occurs. Choice C, this reduces the rates of hospital admission. Choice D, this reduces the rates of treatment failure and increases time to future exacerbations. Or choice E, there's fewer adverse events by doing this. So I'll give you guys a moment to think about this. You can put your answer choice in the chat if you'd like. So the right answer here is that it reduces rates of treatment failure and it increases time until future exacerbations. There was a meta-analysis on this topic that gathered randomized placebo-controlled studies, and they found that the use of the antibiotics reduced the relative risk of short-term mortality by 77%, by treatment failure by 53%, and sputum purulence by 44%. Which patients are antibiotics recommended in? These would be the patients who have moderate to severe illness of their COPD exacerbation, same as what we had for use of oral steroids. But in addition, these patients should have a change in cough or sputum purulence. Recommended length of antibiotic treatment is 5 to 7 days. The choice of which antibiotics you use will be based on local availability as well as your resistant patterns. Common choices we use here in the US include Augmentin, azithromycin, and doxycycline. In select patients, you may need to go broader. For example, with patients with risk factors for Pseudomonas or a known history of colonization with Pseudomonas, you may need to use fluoroquinolones. There's been some emerging data on the use of CRP and procalcitonin to guide whether you start antibiotics. And some studies have shown that CRP use can decrease the rate of antibiotic overuse without increased complications. Procalcitonin has less data, but overall the evidence is mixed. In my own practice, I don't choose to use these biomarkers in COPD exacerbations, but it would not be unreasonable to consider CRP based on your own take of the data. Okay, case question number 6. Finally, your patient is now brought up to the floor from the emergency room, but he's looking worse is now in moderate respiratory distress, appears sleepy, but with his mentation, he's still able to answer questions appropriately. You obtain an ABG and find that the pH is 7.28, his PCO2 is 63, and his oxygen saturation is about the same as before at 90% on room air. What would be your next best step in management? So this is another multiple choice question. A, you want to go ahead and start this patient on mechanical ventilation. B, this patient needs more oxygen, so put them on a non-rebreather mask. C, this patient needs to be sent for a stat CT of the chest. D, it's time to trial non-invasive mechanical ventilation, also known as bilevel. Or E, this patient has not had enough albuterol. Put them on continuous nebulized albuterol. So I'll give you guys a moment to think about what your answer would be. You're welcome to put it in the chat. So the right answer here is you want to initiate them on a trial of non-invasive mechanical ventilation. So what are indications for its use? Per the GOL guidelines, there are three main ones. The patient has respiratory acidosis, a pH less than 7.35. If there's signs of increased work of breathing, for example, use of accessory muscles, or the patient is showing signs of respiratory muscle fatigue. And third, if there's signs of persistent hypoxemia despite using supplemental oxygen. The studies on non-invasive ventilation have shown that this therapy can improve gas exchange, reduce the work of breathing, and reduce need for intubation. And by reducing the need for intubation, this reduces hospitalization duration, as well as improves short-term survival. However, you need to be aware of contraindications to use. This includes significant changes in mental status that make it hard for them to tolerate the mask or be able to take off the mask on their own, facial trauma, upper airway obstruction, or recent esophageal procedures that could lead to detriment from using positive pressure, or hemodynamic instability. So if the patient meets criteria, doesn't have contraindications, then non-invasive ventilation or bilevel is preferred as the initial mode of ventilation in acute exacerbations of COPD. There have been some RCTs done on this topic and have found a good success rate of non-invasive ventilation of 80 to 85%. Now I'd like to pivot and talk about the interventions that can reduce future COPD exacerbations. There's a number of them, and there's some mixed data for some of them. They include interventions like long-acting bronchodilators or inhaled corticosteroids, certain cases using anti-infectives for longer periods of time, such as azithromycin at a lower dose, certain mucolytic agents, and then a number of non-pharmacologic agents. I'm going to focus in talking about long-acting bronchodilators as well as inhaled corticosteroids and when you should choose to use these. So to know how to use these, it's important to be able to stratify the severity of your stable COPD patient. So 10, 15 years ago, the GOL guidelines only stratified patients by their FEV1. So moderate restriction of FEV1 was less than 60%. Severe restriction was less than 30%. But the FEV1 did not tell the whole story. There were patients who had moderate restriction at 60% and patients who had severe restriction at 20%, but clinically, they would act the same. So there's other contributors to severity. And two key ones that have been pointed out is one, the amount of exacerbations they're having in a year, as well as two, their respiratory quality of life as measured by respiratory scales, including the MRC and CAT score. And then by using these two other markers of respiratory function, you can categorize these patients. So group A would be those patients who are not having frequent exacerbations or having mild exacerbations, and they have a better respiratory quality of life. These would be the least severity group. Group B would be those patients who are still not having, or not an exacerbation phenotype, but they're having worse respiratory quality of life. And then the most severe group is group E, This group used to be split into group C and D based on their respiratory quality of life scores, but now they've been lumped under just one group because it's been found that here the most important thing is whether they're developing exacerbations. This is an example of the MRC dyspnea scale. Grade 1 patients would be those patients who get short of breath when hurrying on a level ground or when they get short of breath on a slight incline. Where in comparison, a grade 4 patient would be someone who'd be too breathless to leave their house or breathless when just doing activities of daily living. So what's the importance of stratifying the severity of these patients? It's been shown that there's good separation of survival between these groups. This data is from 2017, and this is when groups C and D were still separated. But what you see on the left side graph is there's a major difference in survival curves between group A and group C and D. And then on the right, you see that group C and D, and per definition now, they necessarily are having more exacerbations, but the rate is 3 to 5-fold in patients in group C and D compared to group A. So now that you've been able to stratify their severity, this can help you choose inhalers. So for a group A, in the least severe group, they may get by with just short-acting treatments or just one bronchodilator. And the long-acting bronchodilator choice would be a long-acting muscarinic agent, for example, Spiriva. In group B patients, those that are having worsening respiratory quality of life, you want to start them on dual bronchodilator therapy. So this would include a long-acting beta agonist as well as a long-acting muscarinic agent. In which patients would you consider using inhaled corticosteroids? These would be patients in group E, the ones who are having frequent exacerbations. So the signal for stratifying inhalers in this way first came from the TORCH trial. This was a trial in 2007 that looked at 6,000 COPD patients and followed them over 3 years. The groups that were randomized to included dual therapy with inhaled corticosteroid and long-acting beta agonists, each of these alone or compared to placebo. So there's 4 groups. It was found that there was no reduction in mortality in any of the groups. However, with the with the inhaled corticosteroid in LABA, this group had fewer exacerbations, improved health status, and lung function. But on the other hand, there was also a signal for harm. There was increased rates of pneumonia with the use of inhaled corticosteroids, with a relative increase of 40%. So the GOLD guidelines have put some criteria out for how you should use inhaled corticosteroids. And so you should consider their use on patients who are having severe exacerbations or frequent exacerbations. So these patients then should be on triple therapy, inhaled corticosteroid, as well as dual long-acting bronchodilators. There's been a biomarker, the blood eosinophil level, that can help determine use of inhaled corticosteroids as well, as patients with higher blood eosinophils have shown to respond better. Furthermore, patients with asthma COPD overlap also benefit from inhaled corticosteroids. Which patients should you think about avoiding use? These would be the patients who've had repeated pneumonias or have low blood eosinophil count, and those who have chronic microbacterial infection. Which patients should discharge on oxygen? The initial data from this came from studies in the 80s, showing that patients who had a resting oxygen saturation of less than 88%, if they're put on 24 hours of oxygen, this had a mortality benefit. However, if you start a patient on oxygen for this indication, they should be reassessed in the coming months to still see if they have an indication for oxygen. Oxygen is not a benign treatment. There are risks to using it, especially those patients with COPD who are still smoking. There's risk of starting fires, getting severe burns. For those patients with COPD who are deconditioned, they can trip over their oxygen tubing and have increased falls. 10 years ago, we extrapolated this data on mortality benefit for using oxygen for less than 88% at rest to also those patients who are dropping with exertion. Our study looking at this was done in 2016, called the LOT trial. It randomized 738 patients and followed them over 1 to 6 years. The groups included looking at those with moderate resting desaturation, 89 to 93%, as well as those patients who are desaturating with exertion. And this was defined as on a 6-minute walk test, they were desaturating into 80s, but not less than 80%. The groups were, one group was placed on oxygen for 24 hours of oxygen for those with moderate resting desaturation, and then exertional oxygen for those who desat with activity. And then the other groups, they did not place them on oxygen. The overall finding from this study was that supplemental oxygen in these groups did not affect mortality. It did not reduce hospitalizations, and also it did not reduce the rates of exacerbations. Furthermore, looking further at the data, they did not find changes in quality of life, lung function, or the distance the patient can walk in 6 minutes. This data has been somewhat controversial because there are patients who desat with exertion in the 80s find symptomatic benefit from using oxygen. But it's important to note when you're using oxygen in these patients, you're not having a mortality benefit. So it's more for quality of life. So it's a risk-benefit discussion with the patient whether to start oxygen. This is a nice figure I found. It's called the COPD value pyramid. It's used in the UK for education on COPD. And what it emphasizes, we didn't get much into some of the other non-pharmacologic treatments for COPD, but they're so important. And what you see on this pyramid is at the bottom, those interventions that are most cost-effective and reduce and improve quality of life years are things like vaccination, flu vaccine, pneumonia vaccine, COVID vaccine, programs to help patients quit smoking, and use of pharmacotherapy when available. And then pulmonary rehab programs where available. These are structured exercise programs that can especially help after exacerbations, and in some studies have also shown to have a mortality benefit. Higher up on the pyramid is these inhalers that we talked about. They do reduce exacerbations, but they are more costly treatments. In many cases, patients can't afford these. So my take-home points for the talk today is recognize the impact of COPD. It's one of the leading causes of death worldwide. That acute exacerbations of COPD change the disease trajectory of these patients, and it increases both morbidity and mortality. We reviewed the core treatments in COPD in moderate to severe exacerbations, and this included the use of short-acting bronchodilators, oral corticosteroids, antibiotics in certain patients. Those patients who are moderate to severe exacerbation have change in cough and sputum, and the criteria for use of non-invasive ventilation as a way to avoid intubations. And then we talked about long-acting bronchodilators and inhaled corticosteroids, and in which groups of patients these would be indicated, and helpful to know the gold groups that help stratify by severity. And we did not get into as much the non-pharmacologic treatments. It could be a whole nother talk, but they're so important. Working with your patient to try to get them to quit smoking, to offer them vaccinations that are recommended, and where available, pulmonary rehab. These treatments are very much underutilized. So these are my references, and in my remaining time, I'm happy to take any questions.
Thank you, Dr. Attar. That was very thorough. Thank you so much for walking us through COPD, classification, and the management. I will hand it over to Dr. Hanan for any comments, and if any of the participants have any questions, please put it in the chat or the Q&A.
Yeah, thank you very much. So it's a very organized, very pertinent presentation. Thank you for that.
Thank you.
I like the way you presented, like the fact that you presented case by case and step-by-step questioning is very good. Thank you very much. Yeah, maybe that is what we follow. We also try to follow to adhere to GOLD guideline. We developed our own national guideline, COPD, based on medications we have. But the current 2024 guideline, the part we like most here is the phenotyping, because the cause of COPD, as you mentioned, is multiple. So if you look at the prevalence of smoking in Ethiopia, even though it is a little bit increasing in a young population from 5% to 8%, still is not a major cause. So community-based studies showed COPD prevalence among those who are more than 30 years, based on more than 700 participants, around 17.8%. So if you look at the phenotyping, would have more of COPD P type based on pollution, household indoor exposure, more female non-smokers. But we also have infectious causes, TB, of course. So what we would change from the GOLD guideline is based on symptoms and previous history of TB treatment. We would do sputum examination for almost all COPD exacerbations, because if you don't have CT scan, difficult to diagnose bronchiectasis. So we do sputum gram stain culture, and if we get Pseudomonas, and we treat as bronchiectasis until we get CT scan. So where I practice in Black Line, we try to follow as much as possible. But for those who are practicing in communities, I would think of bronchiectasis in patients who have excessive sputum production, but not smokers. So non-smokers with excess sputum production would tend to prolong the antibiotics. We do gram stain culture. And of course, we rely on our physical examination. So in times where we don't have ABG, we purely rely on air entry. So we give due emphasis on air entry. So if patient has a almost absent air entry, then would manage the patient as severe exacerbation with the assumption that the CO2 is high and so on. And we also would give non-invasive ventilation. So the problem as a cause of it, we don't have multiplex PCR. So we don't have a means to rule out viral infections. So the way we rule out viral infections is the timing, the season. If there is a seasonal flu we expect, or if the patient has contact with kids. So we have a traditional community where grandmothers, granddads take care of their grandchildren. So if they have a lot of upper respiratory tract infections, exposure and so on, we encourage those to be more liberal in giving antiviral without any biomarker tests. So those are more or less, but well, I really like that the fact you emphasize on vaccination. We really lag behind vaccination, and it's a very cost-effective means of prevention. As you said, it really, really changed the trajectory of COPD. Once patients are intubated in ICU, the outcome is very guarded, very difficult to extubate these patients, especially if they are ex-smokers. They would have lots of thick secretions and fungal infections. As you know, in non-neutropenic patients, COPD is one of the highest risk for fungal infection in intubated patients. So very difficult to treat fungal infection. More likely they have cardiovascular comorbidities. So yeah, so we like to prevent exacerbation by vaccination, wearing masks. So that's what we advise. We advise if they have a family member outside, for them to bring vaccines. We advise them to wear masks, use hand sanitization, avoid kids with flu. And for those who have recurrent exacerbations, we tend to be liberal on azithromycin. Once we rule out MAC infection, so we send sputum culture, we rule out MAC. And then those who have a high pollution exposure, smokers and so on, we tend to be liberal in giving azithromycin. It really works. Yeah, so we'll discuss it as questions come by.
Yeah, that
Thank
was
you.
very interesting to hear about some of these differences. Like even here in the US, in terms of getting sputum cultures or getting viral swabs, there's a huge practice variation in this, whether people choose to get these. And I think you spoke to some of those important points where sputum culture can be helpful. You know, as patients, you're more concerned about having colonized bacteria who had a history of frequent respiratory tract infections. It can be very helpful to know, you know, what kind of bacteria they're growing out. Because even though they don't have a pneumonia, by treating these bacteria, I think this is where we're seeing improvement in outcomes with antibiotics. So that was a very interesting point. Another thing that was, you know, put in the discussion of the goal guidelines and the recent guidelines was during the the COVID-19, when it was more epidemic and there was lower rates of people coming in for COPD exacerbations. They did see that, but they also didn't see a higher mortality from that. So I think the universal masking at that time really helped the COPD population in developing less respiratory infections and then ultimately developing less exacerbations.
Yeah.
Okay, I think there's a question. How often do you give azithromycin in patients who have frequent exacerbation? So yeah, that's a good question. I think here in the US, we frequently go to azithromycin as the first agent for patients with COPD in moderate to severe exacerbations with change in purulence. But if patients are having repeated presentations for exacerbations, or they have other risk factors for other bacteria types or developing resistance, then you would consider doing wider or more empiric antibiotic coverage. And this would include, and I think the next question here is about Pseudomonas coverage. And so that would be some of the thoughts that they could be having bacteria that's resistant to azithromycin. And so fluoroquinolone, despite there's a higher side effect profile with fluoroquinolones, certain patients, you may need to use it. And then in very sick patients who are presenting to the ICU that you're concerned that there is a bacterial component, you may need to use IV antibiotics. You might need to put them on Zosyn. So it's really case-to-case basis. And then it's also important, you know, patients who are on azithromycin, there's side effects of any antibiotic, there's side effects. So you make sure you check a QT interval if you're using azithromycin. So that's what I would say to those questions.
Yeah. So I don't want to send a false impression. So we usually, before we start azithromycin, because our patients in Black Line, they are very sick patients. So we do chest CT scan. So we do chest CT scan, we see evidence. Most of them would have evidence of bronchiectasis, very, very common in our setup. And as you said, if they don't have any hearing issues, no resting tachycardia, younger individuals, very severe exacerbations requiring hospitalization. So we don't. Now, the evidence for COPD, it is daily azithromycin, 250 milligram, 1 year, study published in New England Journal. But we don't usually give daily. So if we have bronchiectasis, we give them 3 times per week, and it really works. 3 times per week. We follow those patients, we give them for 1 year and see. So we use severity grading both. We do also 6-minute walk test. We repeat spirometry. We assess first severity index for bronchiectasis. So it's after a lot of assessment that we decide to discontinue and see them again. So the reason why we don't want exacerbations is, for the next question, is we don't have inhalational antibiotics if they have Pseudomonas. So we don't have inhalational antibiotics. So what we do for Pseudomonas, which we have changed our practice, is we admit the patients. We admit the patients. We give dual IV antibiotics. We plan to eradicate within 2 weeks, and we repeat the sputum culture. And if it is negative, then we put them on prophylactic for both exacerbations and as well as to modify the biofilm. We continue azithromycin 3 times per week for confirmed Pseudomonas infection, because even though you eradicate it, it tends to recur again. And if it recurs, they would go downhill. If their saturation baseline is around, they maintain 91, 92. Once they have one exacerbation, it goes down to 89 borderline, then they would end up having home oxygen therapy. So we want to prevent the long-term complications as well. Yeah, no evidence for that though.
There's a question on mechanical ventilator settings. So I may not know the specifics on this. I don't practice in the ICU anymore, but what I do know is usually you'll want to target the 6 cc's per kilogram to avoid barotrauma to the lungs. Usually assist volume control will be a good mode to use here. And then you want to give them enough time for expiration since these patients have longer expiration.
Yeah. So the whole point is you have to be comfortable on the ventilator setting you are in, and you have to know the pros and cons of each ventilator settings. So the key is you, as he said, you want to prolong the exhalation time, and you follow your patient. So you follow your patient on the flow curve. So you look at the expiratory phase, and if the patient is giving you, if the exhalatory phase has reached to the base and until the next inhalation, then you are safe. The problem is if the exhalation did not finish and patient take another inhalation, then you would end up having auto-peeping and its own complication. So the key is to increase exhalatory time. So you don't have to give 6 ml per kg strict low tidal volume like ARDS patients, so they don't have issues with compliance. In fact, their compliance is very high. So it is okay to give 8 to 10. So the comparison is between 6 to 12. So you are safe between around 8 is fine, ml per kg tidal volume. So if you give pressure controlled mode, then you would follow the tidal volume with that range. So, and if you give volume control mode, obviously you follow the peak pressure because pneumothorax complication is very common. So you don't want to intubate these patients, but if you intubate these patients, if they have pneumonia, so the physiology might change. If they have extensive pneumonia, you want to extubate them as fast as possible. So don't miss the opportunity of doing tracheal aspirates. Once the patient is intubated, it's a good opportunity to know the organism the patient is harboring, good access, good yield. So yeah, it depends on your patient and your knowledge on the ventilator and the settings, the maximum settings. Yeah, I think we are no more.
I think, yeah, there was one question. I don't know the exact answer to it. There was how prevalent is COPD in passive smokers? I mean, certainly secondhand smoke is one of these risk factors that will decrease lung function for sure. But, how often is it that patients will get COPD just from passive smoking? I don't know the exact percentage, but I'm sure there's patients who do have that develop, and especially those patients who maybe early in life, they had exposures to respiratory tract infections, have bronchiectasis, or have lower peak lung function would be at risk.
Yeah, so true, especially if they are exposed early in their life. So those kids where their father or mother is a smoker, very highly likely. So if it is a risk factor for lung cancer, which is more severe, requires more cumulative exposure, so definitely COPD risk. So you could not underestimate. I don't know the figure as well.
Okay,
Yeah.
thank you
I
all.
don't see any other questions. Yeah.
Yeah. Thank you very
Thank you
much.
so much. Yeah, thank you, Dr. Hanan. Thank you, Dr. Attar. Yep. Okay, and the link to the evaluation for this session is in the chat as well. So please take a moment to fill that out. And with that, we will conclude today's session. And I will see you all back on Friday for the next 3 sessions for the general hospital medicine. Okay, thank you all.